It is a 52-year-old female. She was recently underwent a hysterectomy with salpingo-oophorectomy due to a large cystic process. And on the following scan, there was an incidental finding of a 3.2 centimeter lobulated cystic lesions in the tail of the pancreas. The PD is not dilated, so there are not any worrisome features apart from the size, and that's dependent on which guidelines you're following. It was not possible to determine a connection to the PD on the MRI, and the patient is now referred for a EUS-guided microbiopsy and cystic fluid analysis. And the patient has no history of pancreatitis, earlier pancreatitis, and no family history of pancreatic cancer.
Welcome back. I hope you enjoyed lunch. We have, in the meantime, prepared the first patient for you, and you heard the medical history of the patient. The aim is, as you heard, to do an EUS-guided microbiopsy from the cyst or one of the cyst walls. I just wanted to show you the microbiopsy forceps. If I hold it against this and then open it and close. Open and close. Can you see how it manually can open and close? Okay. What we do is we usually prepare the needle or the microbiopsy forceps within the needle. It's a 19-gauge needle. Personally, we use the flex needle from Boston, which is a nitinol needle, and yeah. But I think you can also use other 19-gauge needles for this. If we can focus as well as interior also on the ultrasonic image. What we see, I'm looking at the tail of the pancreas right now, and part of the kidney you can see in the left side of the image. As you see, our direction is also distal to the right, proximal to the left. The tail of the pancreas can be seen now in the mid and left side of the image. And let me try to rotate this a little bit, and you can see now a multiseptated neoplastic process, which we measured to be 3.3 times 3 centimeter. And whether this is a IPMN or whether it's a serous cystadenoma, we can't say for sure. I tried to follow the pancreatic duct, but really the pancreatic duct is so tiny in this region that I can't follow it. I could see it in the mid-corpus, 3 millimeters in diameter, but I lose it here. So I won't be able to tell you whether it has a connection to the pancreatic duct or not. I think we will start the biopsy procedure right now.
Peter, can we ask questions from the audience? I'm
Yes.
trying to do it a bit more interactive. So if any of you have any questions, please raise your hand. My question would be, when are you using the microbiopsy forceps? Can you give us some indications? I mean, are you going to use it in all the cases or only indeterminate cases of EUS-FNA cytology analysis, or what do you think are the indications nowadays?
You know, right now it's a matter of getting information, and it's now in a PhD study, and for the final questions we will not have an answer right now, but I see we are able to change the decisions at the multidisciplinary conferences in, I think, about 14% of the cases. And some of these are really serious decisions, so but we have to see until we have the final study ready. right now we are doing all patients with a cystic tumor above 15 millimeter in diameter.
We have a question. Aika Burmester has a question. Can you say something about the vascularization of the lesion? Could you use Doppler maybe or power Doppler?
Yeah, we didn't do contrast, but we tried with the regular standard color Doppler, and there's not really big signs. There are some signals within, but not major vessel signals. So that didn't give us any clue to as what it could be.
Yeah, contrast is the next question.
That could be an option to do contrast. I don't think we have time for that for this case. So to us, I think it's more of getting a diagnosis based on histology, which is. But I agree with you that at the end it would probably be a multi-way of getting a look into the diagnosis based on contrast enhancements and based on cytology and microbiopsies and CEA, even genetic markers, proteomics, things like that. But we're working on that as well. But this is also for future discussion and a future conclusion on these things.
I agree with you. And with contrast, the problem with contrast here is that you cannot differentiate in between serous adenoma and IPMN. So you can differentiate in between pseudocysts and cystic neoplasms, but not in between serous and mucinous. So, but it's a lesion with a lot of small cysts. So I think at least my opinion would be that it goes more towards the diagnosis of serous adenoma. So,
you're right.
Would you take some fluid initially, maybe do a string test and see if it's mucinous or?
But we will end by taking fluid out.
Okay.
In our experience, it's sometimes very difficult to get fluid, and if it is a serous cyst adenoma, we rarely get any good fluid for analysis. So that's, of course, a problem. And also the small cyst, we don't get enough fluid for all these analyses that we are likely to ask for. So I have to find now a proper place to introduce a needle. The sheet length, I start by introducing the sheet. Here you can see on the left side of the image, maybe Adrian, you can show, I manipulate a little here, which is the sheet length. Here you see it. And then I lock it, not too far down. And next, release the piston. And then I have to get the direction of the needle. And it seems to be somewhere there. If I expose the needle tip, it come here. Might be a little deeper, like this. And as you see, this was more of a punch. And now I have the needle tip in. Can you show where that is?
Yeah, we can see it here, I guess.
Yeah. And I introduce the biopsy forceps, the micro forceps. And can you open the forceps? And close again. I did get and open again. Try to get a bite, and you lock. Close. Not satisfied. I retract the needle tip a little bit. It might be stuck onto open. There you saw it opening, and put a little pressure on close. Yeah, that was better. Could you retract it? Sometimes it sticks to the. It sticks to it. Yeah. Eller, maybe Hasim, you can do it.
Hvad er problemet for nu?
Den sidder lidt. Sometimes the specimens are so big that it's a little difficult to get into the needle again. Yeah, and try to.
Hold nullen, Peter.
Hvad?
Du holder nullen?
Jeg holder den nullen. Okay, it got it. Yeah. You know, sometimes the specimens are really so big that
okay.
It's difficult to get it in to the needle again. And of course, you need to, if it is impossible, then you have to retract the entire needle and then start the process over when you have taken the material out. Usually, no. We take maybe one more biopsy, unless if you tell me whether it has. It's a big specimen. Okay. So it's a nice. It's very nice. Is it possible to see from the camera? Can I have it? No. Only if you have it.
Can the camera? No. It's on the thing.
Det er svært.
Yeah,
it's possible.
Is it possible to see this? Let me see whether I can see it. Yeah, you can see it. I think you can see it if you focus on that. Can you see it?
Yeah, that's okay. Perfect.
Okay. So now we will use suction. See whether we would get any cytology and also fluid. Can I have
suction?
Suction? The aspiration syringe. You know, it was interesting for me also to notice. See how it? Did you see how it emptied? Yeah, that it actually emptied the cyst. And let's see here. It was interesting for me to hear Thomas Huckel's lecture, where he said that it's not enough to release this or to lock this, because the suction will stay on. And I fully agree. That is also what we do. It's a little bloody. Can you see that? So that might be compatible with a serous cyst adenoma, that it is a microcystic. But you see, it doesn't fully empty due to these many cysts, I think.
Symptom.
But I have it here.
What markers are you planning to use, Peter?
What?
What are you going to do? Only cytology, or are you going to do
if we have enough
CEA,
fluid, we will do cytology and CEA as well. I think that would be our choices. Basic, that would be our choice. But as I told you, very often we are unable to get enough fluid. This is coagulum, so I think it's fine with this. And we have to see. We will present all these material as much as possible tomorrow, so that we can discuss how it looks.
Peter, I have one question. If the pancreatic duct is interposed, so that you have to cross the duct to reach this lesion, is this a contraindication or not?
You know, usually this is what people usually say. It's a contraindication. On the other hand, we also do microbiopsies of main duct IPMNs. So the idea here is, of course, that we want to also subclassify main duct IPMNs if we can restrict some of the patients from surgery. Maybe not, but at least we want to see whether we can better characterize these patients. I think we are done. If you can release the suction and take it off. And that's what we always do also in FNAs. And now I retract the needle. By the way, regarding the main duct involvement and the penetration of a needle, we have had some pancreatitis cases with this method, but none of them have been with needles sticking into pancreatic ducts.
Yeah,
so,
any other questions, maybe from the audience? Yep.
We have to hear how far they are prepared in the other room. Otherwise, I will
just a moment, Peter. We have one question for you.
Yeah.
Hi. Would it be technically possible to put a fiber optic scope down there and actually have a look inside?
Yeah, that would be possible as well. There are cameras with a size of that dimension.
Because
we also have CLE. As far as when we are doing this study, it is very often difficult both to do microbiopsy as well as CLE, because some of the normal cysts, they just empty themselves upon penetration, and the longer time there is going, more and more empties. So that makes it more and more difficult to get the microbiopsy, as well as also in case we want to do NCLE.
Yeah.
But I agree, definitely we need studies that show a comparison between these two. But there are some logistical problems based on it.
Yeah, because with mucinous lesions, with IPMNs, it would be of some use if you could actually direct where you put where your biopsy came from, because some parts of the cyst may be quite flat and not that interesting, and other bits may have the excrescences and all the all the interesting bits, which we may have the more high, because they can vary quite a lot in which areas are more sort of complex and more likely to be high grade and diagnostic. If you could have a look first and then put your biopsy in,
and then target your biopsy.
Yeah, exactly. Yes. Yeah.
Yeah, the idea is good. I doubt whether smaller cysts that there's time to do that. Bigger cysts, yes, it's a good option, but still scientific questions.
Thanks.
Yeah, and in the meanwhile, I think I will go to the duodenum,
Lena,
just to show some of the anatomy, as long as they're not ready in the other room.
We have one more question, just a little bit.
Yes.
Can you say that?
Hvornår skal de afslutte?
Okay. Are you using antibiotics, Peter? Prophylaxis?
Pardon, I didn't understand.
Do you use antibiotics as a prophylactic measure in all the cysts?
We do antibiotics in all our patients, and we even do also Ringer's lactate, which is, there's no evidence, but there is evidence for ERCP with this. And we also give the patient NSAIDs, rectal NSAIDs.
How long are you staying in the cyst? Are you following? There were some initial concerns with NCLE, and the initial report stated that you should stay less than 2 minutes, or 1 to 2 minutes when doing the imaging with NCLE. Would you respect that when using the microbiopsy, or
Yeah, usually it doesn't take very long to do the microbiopsy. It is very, very quick. Just want to show you the anatomy here. As you see here, the pancreatic duct and the CVD. Oh, CVD and pancreatic duct. So this one is the pancreatic duct, the papilla. Maybe you can point to Hasim. Pancreatic duct towards the papilla, and a quick turn the CVD. And the head of the pancreas that we see here, if we follow the CVD upwards, and at a point we need to turn, and you see here the CVD in a transverse scan, and I think it's the cystic duct that is merging with the CVD here.
Portal vein.
No, yeah, portal vein and the cystic duct here. And the gallbladder is coming.
Peter, could you show us again the pancreatic duct and how would you differentiate the pancreas divisum? Just for the audience.
That's not. I'm, let's say, not the right person to ask that. That with the linear, it's. I think I'm not very familiar with how you should do that, but at least this
Peter,
is the...
Peter, I think this is a divisum. You see that the pancreatic duct, this is the common bile duct, this one, and underneath you see a very small, in the head, another duct, and this is the Santorini. It goes to the minor papilla, I think.
Oh, this one?
This is the small one, yes, this is the head part.
This is the head, so yes. This is the...
So I think it's duct. A complete pancreas divisum.
Wow, okay. And this one is the Santorini. This is the duct for the minor papilla.
Yes, I think so.
Yeah. Okay. Yeah, you're right. You're right. And here I can follow the pancreatic duct. But here it somehow gets small and I can't follow it longer. It might be somewhere in here. And now we approach the cystic lesion there, I think.
That's the column pancreas.
Yeah, we have your ready. And here you have the pancreatic duct again, and then I think I went out. Okay, I think we'll finish here, and then we'll move to the other room.
Thank you very much, Peter. Thank you very much. Very nice presentation. Thanks.
First, a microbiopsy was taken from the cyst wall, and afterwards, fine needle aspirate was taken. Okay, so this is a slide showing the fine needle aspirate. It was very bloody and contained only a few cells dispersed in the blood and fibrin. So if we had only this fine needle aspirate, we would not be able to give you a definite diagnosis. So this just to show that in this case the fine needle aspirate was insufficient. Luckily, we also received the microbiopsy, and even though you found that this was a huge microbiopsy, it measures only 0.5 millimeter in diameter. Anyways, it's in this case it's proved to be sufficient. I'm just looking for it. Here it is. What we're looking at is the microbiopsy, and it's quite small, but sufficient for diagnostic evaluation. And one can see that it consists primarily of stroma, but on part of the surface you can see a columnar epithelium, and the columnar epithelium is mucinous. I don't know if you can appreciate the mucinous cytoplasm of these columnar epithelial cells, but you should be able to see that the nuclei of these cells are quite bland, similar, and located basally in the cell. So this is histologically this is a low-grade mucinous epithelium, and when the stroma of a mucinous cyst looks like this, it's suggestive of an IPMN. The epithelium most of all looks like gastric epithelium more than pancreatic biliary or intestinal epithelium, and thus this is most likely an IPMN of gastric type and with a low-grade dysplasia. So that's our
subtyping. You will do that afterwards.
It's true. We would do some immunohistochemical stains to subtype the lesion, and unfortunately we haven't had the time to do that from one afternoon to the next. But we would expect this to stain in the gastric markers and not in the intestinal and pancreatic biliary markers. It's not always very easy to do this subtyping, and there's some uncertainty as to how the different markers stain the different subtypes, but we would certainly expect this to come out as a gastric subtype.